Welcome to this new edition of the Fujita Health University Bantanei Alumni Association webinar. First of all, I want to welcome Professor Yoko Kato, of course, who is the mind behind this organization. And thank you to Dr. Raja for helping with the organization. I welcome also Professor Ishu Bishnoi, who will be my co-moderator today, as usual. Hello, Ishu.
Hello, everyone.
Thank you. So today we are all very excited because we really have big names for this webinar. We have two great speakers, Professor 𝒕𝒊𝒃𝒂 and Dr. Sachin, who is also a great friend of all of us. And we have two great discussants today, Professor Michihiro Kono, Chairman and Professor of the Department of Neurosurgery, Tokyo Medical University in Japan, and Professor Akihide Kondo, Chair and Professor of the Department of Neurosurgery, Juntendo University in Japan. Also, Professor Hirotoshi-san was supposed to be here as a great commentator, but he told me that he is traveling, so he was not sure to be able to connect. Hopefully, he will connect soon. Anyway, let me ask Professor Yoko Kato to say a few introductory words to this webinar before the introduction of the speakers.
Sorry, phone call from Dr. Sano. So please go ahead. Please go ahead, Albert. Please go ahead.
Yeah. So let me introduce the first speaker, Professor Marcos 𝒕𝒊𝒃𝒂. Professor Marcos 𝒕𝒊𝒃𝒂 doesn't really need any long introduction because he is very famous, but just a few words. Professor 𝒕𝒊𝒃𝒂 completed his medical study in Brazil and then his neurosurgical training at the Department of Neurosurgery in Hanover, Germany, under the chairmanship of Professor Majid Sami. He has been research fellow at the Institute of Brain Research, University of Zurich, and he then was appointed as associate professor at the Hanover Medical School and the International Neuroscience Institute of Hanover. And since 2003, he is chairman and director of the Department of Neurosurgery at the University of Tübingen. He got several prizes and he had many roles in different academies and societies. And he is author and co-author of about 450 peer-reviewed articles and several books and book chapters. Today, Professor 𝒕𝒊𝒃𝒂 will talk about a very intriguing topic, actually. The title of his talk is Surgery of Vestibular Schwannomas in the Era of Radiosurgery. So I kindly ask Professor 𝒕𝒊𝒃𝒂 to start his lecture. Thank you, Professor.
Thank you, Alberto, for these very kind words. It's a great honor and pleasure to be with you. I would like to thank Professor Yoko Kato for initiating this webinar series under support of so many famous professors and neurosurgeons from Japan and all over the world. So I would not mention all of them. All of them are very important people, and especially I have good friendship with many of you who are participating here. I would like to share with you my screen, and I hope it will work well. And I hope you can see my slides right now.
Yes, we can see that.
So this is, as you have mentioned, this is a topic that has been discussed pretty much in the last decades and the last years. And I would like to continue this discussion sharing with you our experience we have accumulated in the last 26 years. So this was my personal development in surgery of vestibular schwannoma. I started my residency program 97. You see a Nordstadt hospital, Professor Majid Sami here, and I was this guy here on the corner, just starting my residency program. And 96, I got the opportunity to operate my first vestibular schwannomas. And during this period here, 9 years, I was participating in several hundreds of surgery, and this was my learning curve at the beginning. So I would like to mention this because this is part of the development to work in a center where this surgery is being done almost every day. So you are very much involved with the discussion regarding indication, results, and everything. So, and then I continued this work at the Hanover Medical School, at the INI, as you know, the International Neuroscience Institute in Hanover. And then I moved to University of Freiburg as vice chairman 2002. And since end of 2003, then at the University of Tübingen, where we could increase the numbers of this surgery a lot in the last years. We have done per year more than 100 cases. At the beginning, it was just 4 or 5 cases per year. So it means there is a need of treatment of these patients. So for medical students or young residents, vestibular schwannomas belong to the most common benign nerve sheath tumors. And this is the most common tumor at the cerebellopontine angle. It arises from the Schwann cells of the 8th cranial nerve, and the incidence is 1 to 2 per 100,000 people in general, but in the older population, it can be 3 to 4. It's more common in older people. And this is this paper in New England Journal of Medicine summarizes the today's concept of treatment of vestibular schwannoma. It's worthy to read. We know that most cases are benign. The large majority of vestibular schwannomas are benign, but these tumors may appear completely different. They can be small, they can be giant, they can be bilateral, they can be cystic, regular borders, irregular borders, entering the canal, without entering the canal, cystic ones. So, and then when we talk about indication, results, we are talking about the general and average data, but depending on the appearance of the schwannoma, everything will be different. So maybe it's sometimes important to collect the cases separately, for instance, only the intercanalicular, or only the cystic, or only the giants, or only the neurofibromatosis type 2, in order to have a real idea what is going on with these cases. Aggressive behavior is very uncommon. We have seen 2 cases in 1,000 people, and now we are approaching 2,000 cases. We have had 3 patients. 2 of them had been irradiated before. 1 was spontaneous. This is a case of spontaneous malignization. You see here, we operated this case 2012. Everything was fine. This is the control April 2013. And the patient came back 1 year later with this explosion of tumors. We were very surprised. And this was malignant tumor. We removed that. Patient was irradiated, but died shortly after on metastasis everywhere. But actually, in the most cases, the tumor will grow very slowly. We have extreme case of almost non-growing tumor. You see here many years, absolute control of this tumor, although we cannot say for sure that this is vestibular schwannoma, but it appears like vestibular schwannoma. And on the other side, you may have a tumor like this. Within 3 years, presented a good growth. And this is the reason when we detect the tumor for the first time and the tumor is small, we prefer to do a control of the tumor 6 months later and not to wait too long. But on the other side, we don't like to operate tumors that are not growing. So in average, vestibular schwannomas will grow 0.5 millimeter to 1 millimeter per year and will double the volume within 4.5 years. Because of this behavior, several recommendations appeared. One of these is observation, of course, and then surgery, but surgery can be done by different methods, and radiation can also be done using different methods. And then you can combine the treatment, surgery, radiation, and so on. And there is also the option of chemotherapy in selected cases of neurofibromatosis type 2. The point is that today there is a very low level of evidence to provide treatment recommendation. This is true, this is fact. And many patients will come very confused to our office because they have read a lot on the internet or have heard a lot of different recommendations. So we are almost every day confronted with this situation. A patient is coming saying that in another center, surgery was recommended, in the other center, radiation has been recommended. So this is a difficult situation. 2 years ago, the neuro-oncological group of the European Association of Neuro-Oncology has done an examination of the literature, and they selected the most important papers and did a summary. This is a meta-analysis of the literature. And this paper shows in a very clear way all strength and weakness of such a meta-analysis. Because, of course, their recommendation was based on the data that has been published. And that's the point that I would like to mention, because people doing observation or people doing radiation are publishing more than people doing surgeries. And so that good surgical series, well-controlled series, they are not very common. And this makes the total literature a little bit weak in regard of surgical recommendation. So the key points of these papers are, you can read here. This is a summary of the key points. Observation is considered for incidental asymptomatic vestibular schwannomas. As alternative to observation, radiation can be performed. End of the sentence. But what about large asymptomatic vestibular schwannomas? Shall we really follow these recommendations? This question has not been answered. And another key point, for small vestibular schwannoma, where facial preservation hearing is the primary goal of treatment, radiation over microsurgery may be chosen. This is based on the published literature. But what has not been discussed in this paper is, what about small vestibular schwannomas in very young people? We see these cases, 20 years old and a little bit more, young patients, young women who want to become pregnant. Shall we really follow this recommendation? So this question has not been addressed as well. And in large vestibular schwannoma, surgery has been considered primary treatment, but to reduce mass effect. No words about complete resection here. So the question is, what about management of recurrence? So this has not been discussed in this paper, because all of us know that treatment of recurrence is much more difficult and the results are completely different. So this has not been addressed as well. And that's the point, the reason why we see with critical eyes this paper that has been published 2 years ago. Fact is that no single treatment can alone offer the final solution for all cases. So we have to combine treatments. Sometimes radiation is really the best option, but sometimes surgery is the best option. So the choice of treatment, in my opinion, will basically depend on tumor size and characteristics of tumor, whether it's solid or cystic. Cystic ones are unpredictable. They can grow very fast. And also patient's age and physical condition. Of course, if the patient is old, then there is a tendency to go for radiation. But if the patient is very young, then surgery, in my opinion, is the best option, not radiation. And the results of this decision will also depend on the experience of the treating center. So it has been shown that in large centers, the results are better than in centers where 1 or 2 cases per year have been treated. Basically, the goals of the treatment will be cure or stabilization of the disease and preservation of quality of life. This is clear. In my opinion, this is a clear case for radiation. The patient is 69-year-old and the tumor is growing slowly. So this would be, in my opinion, a good recommendation, provided the patient is not suffering too much from vertigo. But this case here, also intracanalicular vestibular schwannoma, like the other one, but the patient is very young. And in this case, in my opinion, a good surgery will be superior. Patient can really benefit from surgery, can be cured from this disease, and if the surgery is well done, the function is preserved. So in young people, the preference would be surgery. Surgery can be done through different methods. We prefer the retrosigmoid approach, translab approach only for large tumors, but even for large tumors, I prefer retrosigmoid approach in sitting position. And I don't like so much middle force approach because of the risk of damage the temporal lobe, particularly on the left side, as you can see here. So these cases may be more associated to neurocognitive disturbances, depression, mood changes, and so on. So our strategy is to do supine position in small tumors and semi-sitting position in large tumors. In my personal experience, I do see advantage of semi-sitting position. This is the position we use. The legs are positioned superior to the head so that we don't have cases of air embolism, which could cause trouble to the patient. And this is the position of the surgeon. You see, the arms are not stretched. The arms are comfortable, resting on this bar, and the head is in a good position. So I personally don't have back pain. I don't have neck pain or muscle pain after these surgeries. I must say to all people who believe that the position is not ergonomic. So this is not my experience. And there are some papers comparing supine and sitting position. I don't want to discuss too much this paper, but this is a prospective analysis of these cases, and the authors, we participated on this study as well. So surgery is faster, rate of tumor resection is higher, and facial results were better using semi-sitting position. So there was no significance for hearing. I guess for these, we need more cases than 97. So in this is a retrospective study we have done with more than 800 cases, and you see no single case of severe air embolism. You will find some bubbles, but they are not significant for these cases, if we follow strictly the protocol indicated by the anesthesiology. What we have seen is 3% of pneumocephalus that required air exchange. So I'm telling all of this because these data are also important to discuss treatment recommendation, surgery versus radiation. So this is our surgical indications. Large tumors with brainstem compression, this is clear. although we try to do maximal tumor resection, we try to do complete resection, but we know that in 1/4 of the cases, this is not possible, and then we leave some tumor behind. This is our series. Cystic tumors, they are unpredictable. As I told you, they may grow very fast. Young patients below 60, if they have small tumor, we go for surgery. And then if the patients have basically vertigo, severe vertigo, even with small tumor, we go for surgery. I explained to you why. In our experience, this patient will benefit from the neurectomy of the vestibular nerve. And if you observe carefully these cases, you will see following. Look at this. This is a finding that we may have in these cases. The subarcuate artery was really strangulating the vestibular nerve and the cochlear nerve. Similar that we find with the A1 against the optic nerve in cases of suprasellar meningioma. So we may find the same thing here. So the vertigo like this will not improve following radiation. And but surgery can solve this problem of vascular compression or disease of the vestibular nerve. And of course, the neurofibromatosis type 2, we try to open the internal auditory canal and do a tumor release. We release the size of the tumor in order to keep the quality of life of patients. And of course, also patient individual decision. Some patients are against surgery or some others are against radiation. So we have to respect this as well. Monitoring is fundamental. We use facial MEP and EMG and also auditory evoked potentials and also recording of the lower cranial nerves in large tumors. We can also do free running EMG. I guess Professor Kono will be happy I'm showing this picture because he's pretty much supporting this technique. This technique is very good as well. And also direct recordings of the cochlear nerve in some specific cases where we don't have good AEP waves. So our technique is basically retrosigmoid approach, but I must mention that you must do everything to open the bone below in order to have in sitting position for large tumors. Your target will be from below to above. You see how the spatula is supporting the cerebellum. The opening below is higher than above in order to avoid stretching and rupture of the petrosal vein and to give you the chance to see the facial nerve very early. So we open the internal auditory canal at the area we call Tübingen line here, and then the canal will be located above this line. The first step is to open the internal auditory canal, and at the end of the surgery, we can have a look inside. Even in cases we don't open the full canal in order to preserve the labyrinth block, we can have a look inside. So I would like to show you two cases, one small and one large, very quickly. You see here, young lady, 26-year-old, resident in general surgery in another hospital. And of course, I would not recommend radiation. I mentioned the radiation. If she decided for radiation, I would respect her decision, but I had to tell her my opinion, that is, try complete resection, preserving the function, but she must know that there is a risk of hearing loss. Of course, she must know that, and she must be able, in worst case, to accept hearing loss. Facial palsy in these cases are extremely uncommon, so we don't have severe problem with the facial nerve in these small tumors. But of course, hearing is an important issue. But you see, it was possible following auditory evoked potential monitoring to preserve hearing. You see here at the end of surgery, auditory evoked potential waves very nicely preserved. and facial in good condition. This is the way we open the dura mater, singular incision, so we can close the dura always without need of grafts. And this is a larger tumor, incidental finding, good hearing. The tumor was growing. We observed this tumor for 6 months. It was growing. So we decided for surgery. I would like to show to you just some steps. You see here the craniotomy, retrosigmoid craniotomy. The basic part of the craniotomy is very well opened. You see here, we open the cisterns at the first step, and then the intern auditory canal. You can visualize the lower cranial nerve at the beginning of surgery. This is an advantage in comparison to translab approach. So we open the intern auditory canal, and then we remove the tumor from inside the canal, and then you see here incision of the tumor, send material for pathology and studies, and then quickly reduction of tumor size with CUSA, and then we start the mobilization. You see here, this is the cochlear nerve below, and you see the artery strangulating the structures. This is a very common finding. And then the advantage of sitting position. So we don't use bipolar, we irrigate the field all of time and separate the structure. We separate the facial nerve, we separate the cochlear nerve. The resident is irrigating the field with papaverine solution, and we keep the middle arterial pressure above 80, between 80 and 90 millimeter mercurium. So you see here final removal. It was not complete, but near complete removal. I will show you the MRI later on, and we could preserve hearing in this case as well. You see the auditory evoked potential, and this is what we could achieve. Is a good resection. There is a thin remnant in the intern auditory canal to preserve hearing of this patient. Facial was well preserved. Hearing was well preserved. Also the balance of the patient. You see here we are following this case for more than 5 years now, and this remnant remained the same. So I'm happy that the decision was surgery, near total resection, so we could solve the problem and the patient is in good condition. We have several cases, follow up 10 years, 13 years, and there is a risk of recurrence. And we can see in this paper published by Nakatomi, 2017, but the risk of recurrence is much higher in subtotal resections. So this is another case. Patient was musicist and working a philharmonica. So we could do a good resection of the tumor. The facial nerve was initially not perfect, but then recovered, and the patient was able to play his clarinet again. If hearing is preserved after surgery, there may be some deterioration over time, but basically the hearing has a tendency to stay stable or more stable than after radiation. This paper from the Italian group is showing that, and the Japanese paper is showing the same. There may be some deterioration over time, but still this is more stable than following radiation. And there is another interesting advantage. If there is some deterioration, but the tumor is removed, so the patient may benefit from cochlear implant. We have this case here, total removal. The patient had some deterioration. After cochlear implant, the patient improved a lot and getting the hearing normally again. Some words about facial nerve. You see, even a large tumor may be associated with Haus-Bregman 1 post-op result, as this case as well, this lady as well. This other case has a Haus-Bregman 2. We may find Haus-Bregman 3 or more in larger cases or cystic cases. But what happens with these with this deterioration of facial nerve is what you can see here on this graphic. The patients may deteriorate, but over time they will improve. So that in small tumors, the rate of 𝐹𝑢𝑗𝑖𝑡𝑎 3 or more is 1%. For large tumor is this percentage higher, but still 75% of the patients will have 𝐹𝑢𝑗𝑖𝑡𝑎 1 or 2 following large tumors. So these patients here, they all developed 𝐹𝑢𝑗𝑖𝑡𝑎 4 after surgery, but later on they developed to 𝐹𝑢𝑗𝑖𝑡𝑎 2 and they were satisfied. And in some cases, we have to do subtotal removals, particularly if the patient has already facial palsy before surgery. These facial nerves are pretty much under risk. So in these cases, we do subtotal removal. You see here it was not possible to remove the tumor from the facial nerve, but the patient got a quite satisfactory facial result, 𝐹𝑢𝑗𝑖𝑡𝑎 3, and is still improving. Now, finally, quickly, the results of this a retrospective study we have done comparing two large groups treating vestibular schwannomas, the gamma knife group of Krefeld and our group. We had a total of 1,000 cases retrospectively analyzed. We separated the previously operated cases or irradiated cases or recurrent cases or neurofibromatosis. So we had a total of 901 patients for our study, and we compared 559 radiated with 342 operated cases. We had a mean follow-up of 7 years in these cases. Radiation treated more small tumors than larger tumors, but both. And surgery operated more larger than small, but actually both. So in terms of hearing, radiation was able to preserve hearing better than microsurgery in general. You see here Gardner-Robinson 1 and 2. These are general results. And radiation was able to preserve facial nerve better than microsurgery in general. You see here 𝐹𝑢𝑗𝑖𝑡𝑎 1 and 2. But if we divide the tumor into different sizes, we'll see that surgery had exactly the same functional results like radiation. For large tumors, radiation was better. But for small tumors, the results were very comparable, both for hearing and for facial nerve. And for these large tumors, we observed a better result following radiation. However, these patients had more frequently recurrences. For tinnitus, vertigo, trigeminal symptoms, surgery had a tendency to produce more amelioration of the symptoms than radiation, as you can see in this graphic here. And regarding tumor control, surgery was better to produce control of the tumor in comparison to radiation. You see 4 against 11%, particularly for large tumors. For small tumors, tumor control were similar. We could not find significance comparing surgery with radiation, but for large tumors, surgery was pretty much better in producing tumor control. This is very interesting. In summary, we could find that tumor control was comparable between both methods for small tumors. And but functional results were also comparable in small tumors between radiation and surgery. For large tumors, functional results were better after radiation in comparison to surgery, but surgery was superior for tumor control in these large cases. Considering the secondary symptoms, tinnitus, vertigo, trigeminal symptoms, microsurgery was better than radiation. And we have seen that if we are going to combine treatment, surgery plus radiation, in order to have the real advantage of radiation, we have to reduce the tumor size until cause or Hanover grade 2 size. So these results we found very interesting because they helped us in decision making for future. And this is what I want to show to you today in order to have all this research done retrospectively, prospectively, and basic science. In these cases, we need a good team. I'm very happy to my group and also group of ENT and facial reconstruction team for their work in this field. Thank you very much. It was a pleasure to be with you.
Thank you.
Thank you. Thank you so much, Professor Tatajiba. I see we have Professor Sano also, who was able to connect. So thank you very much, Professor Hirotoshi Sano. Maybe you want to give some comments.
Yeah, but very great. But there is a discussion also that especially the acoustic pneumoma, maybe the Kono is one of the specialists of in Japan. So the Professor Kono, are you there?
Hi.
Yeah, you can
Yes.
you can discuss about that.
Okay. Before discussion, can I see some slides? Is it
Sure.
okay?
Yeah,
Yes,
please.
sure.
Yoko Kato, so ordered me. So
Yeah, you can share your screen.
okay. Can you see?
Not yet.
No, not yet. Okay. Sorry.
Yeah, maybe.
Okay.
Yes, now we can see.
Nice picture.
Okay. Hi everyone. I'm Professor Kono from Tokyo Medical University, Tokyo, Japan. Marcos is my dear friend, and so we are the same generation. And so it's my great honor to be here. And the key points in vestibular schwannoma surgery, I think, the continuous facial nerve monitoring, Tatajiba said, and the wide and deep opening of the posterior wall of the internal auditory canal, lateral to medial dissection in ISC, 7 gates, and 3 dissection planes in tumor removal. So this is the continuous facial nerve monitoring. We reported this method more than 10 years ago. After identification of the root exosomes of the facial nerve, I placed an electrode for continuous facial nerve monitoring with 1 Hz frequency. About the lateral to medial dissection in ISC, like this, under the monitoring, of course. And 7 gates, fundus, both sides of the ISC, both shoulders. And this is a very important area for doing continuous facial nerve monitoring. And this is the area for internal decompression first. And about the 3 dissection planes, I believe vestibular schwannoma is the most vestibular schwannomas subarachnoid tumor. So this is the arachnoid membrane, most outside, 7th and 8th cranial nerves, and this is the tumor capsule derived from the vestibular nerve fibers and the tumor itself. So we can select these 3 dissection planes. In this case, right side, cutting into the tumor, and after internal decompression, I found the root exosome of the facial nerve, and after starting the continuous facial nerve monitoring, internal decompression like this, and I'm following the facial nerve like this. And the internal auditory canal is drilled deeply and widely. And I found the facial nerve here. This is a very transparent facial nerve. And this is a very thin cochlear nerve here. And this is a tumor capsule derived from the vestibular nerve, different planes. And this is a naked, transparent facial nerve here. And this is a tumor capsule, different planes. And also, I'm leaving a tiny tumor on the tumor capsule. So 3 planes like this. In this case, furthermore, I could see the arachnoid membrane over there. And this must be the perineurium of the vestibular nerve covering the facial nerve. And I left the tumor here. So our series, 1,700 cases, postoperative facial nerve functional preservation rate with a Hausen-Bergman grade 1 or 2, 1 year after surgery, 97%. Very good. But unfortunately, the 8% of our patients required additional treatment, mainly treated by radiosurgery. So that's all. Sorry. Oh. And so, I totally agree with Tatajibba's policy, and also ANO guideline has so many issues. I think the guideline doesn't include the age element, and also the hearing preservation surgery. So, and the authors of the ANO guidelines doesn't have real surgeon. Only Starker from ENT doctor. Marcos should be included to do the ANO guidelines, I think. So you should you should react for the against the ANO guidelines. I'll help you. And
yeah, we have to write a second paper.
Okay. All right.
Okay.
And also for younger patient, my policy, of course, I will recommend surgery for middle-sized or large size. For small size tumor, for younger patient, if the he or she has useful hearing, so I would recommend hearing preservation surgery. I agree with you. So more than 60 years old people, we will recommend radiation surgery for middle-sized tumor, not small size. Small size is wait and scan. It's enough, I think. Larger one, of course, we have to do surgery. And also, so I totally agree with Tatajibba, except for the position, surgical positions. we like lateral park bench position. Yeah. Kondo, Professor Kondo.
Professor Kondo.
Your turn.
Yes.
Yeah, maybe
Yeah.
you want to comment.
In my turn. Okay.
So already two big names talked about that the indication of the vestibular schwannomas, and then also I'm not like specialized for the vestibular schwannoma, but I have more than 100 cases. So that I just want to mention something about the small size of the vestibular schwannomas. As you may all know, that I already have some paper had published that very small vestibular schwannoma can like having that radiosurgery, and it's having like a good like hearing preservation, and also they can control that the tumor sites. And also like otological physician also insists that if that SDS speech discrimination test is wonderful, is it like not like suitable for the surgery? How about your idea, Dr. Marcos? I can show you that the slide of the literature here. So I just want to share the one slide. Yeah, here you go. Okay. Can you see this slide? This is a radiosurgery for that very small vestibular schwannomas. And also that the Japanese otologician already said that if the speech discrimination test is wonderful, that the hearing preservation rate is good. So can you give me some idea for this like informations?
So if I have to comment, there are several other papers showing that hearing deteriorates after 5 to 10 years following radiation. And my problem with these is that most papers showing hearing results, they don't have long follow-up. They don't have enough follow-up. So you need at least 5 years or more in order to study the results of radiation. And what we have seen is that when you remove the tumor totally in small tumors and hearing is preserved, usually this preserved hearing remains somehow stable. It may deteriorate a little bit, but basically remains stable. And then you can use cochlear implant because the patient doesn't have any tumor. So you can use cochlear implant. Following radiation, there is some difficulties to put a cochlear implant because you will not be able to follow up well these cases because of the artifact caused by the cochlear implant in these patients. So because it has been suggested as well that hearing deterioration after radiation to be compensated with cochlear implant. It can be done. Yes, it can be done. However, it's not without dangers because you cannot follow up the patient well. So, I have seen one very dramatic case, young patient with small tumor being radiated, and then she become pregnant. And after the pregnancy, this tumor exploded and became malignant. So these cases exist. We cannot say they don't exist. And this patient died. In my opinion, this is a case of mortality after radiation, because it has been said that only surgery can cause mortality. Radiation cannot. Of course, immediately after not. But at long term, if you are seeing many cases, you will pick one or other with this severe complication.
Thank you. I think Professor Tzadzajiber, and actually, that I'm a neurosurgeon, so that I'm pretty much the side of the microsurgery now. But in some cases, we need like an excuse or explanation about these kind of like information. So it's good. So now I don't like to use the radiosurgery for the young people, and also that we cannot expect that. Let's say that any like poor prognosis or malignant mutation of the radiosurgery, so that we have to avoid that. So I'm totally agree with that. But your comment is wonderful, and I just wanna use that your comment tomorrow in my clinics. Thank you.
Thank you very much. Arigato. Professor.
So that's my comment.
Thank you for these comments. Professor Kono, do you want to add something? Or we can maybe open for discussion if there are some questions from the audience. Of course, for Professor Tatajiba, but also for Professor Kono.
Tatajiba. So, what do you think about the intended subtotal removal plus radiation? So, my opinion, there are no actual long-term result. So I want to do that. But so same opinion.
Yeah, we are now making an analysis, and I hope we can publish this paper soon. We have done an analysis of all patients we have operated after they failed surgery or they failed radiation, and the results are much, much worse. And in my opinion, you must include this second treatment when you discuss the primary treatment of the radiation. You know, so if you have 100 patients, you operate these patients, you may have 4% recurrence surgery. Okay, so these people must be treated by surgery or radiation. The results will be worse than the primary treatment. After radiation, we have seen 11% recurrences. The treatment of the recurrence will be also more difficult. The result of the treatment of this recurrence, in my opinion, must be included in the general analysis of the whole treatment, you know, and the more subtotal removal you do, the more recurrences you will see. This is, in my opinion, not the best way to treat the patients. The best way is to learn the technique. If you want to do that, go to a center, go to Professor Kono, go to a center who is doing this surgery every day, almost every day, and then you will get the experience, and then you can do yourself. So, and not listening. This workshop is excellent, but it's not sufficient. So just listening lecture, then you start yourself. Of course, subtotal removal is very easy. Everybody can do subtotal removal, but this will not really finally help the patient.
Thank you.
So you showed, Professor Tatajiba, some cases where you left a very small remnant. When do you decide to stop the removal? Do you base on monitoring, I guess, or?
Yes, so usually it was because of the facial nerve, and usually it was in large tumors. We could not remove the tumor totally in 1/4 of our large tumor cases. So T4, cause4 tumors, in 75% we could, in 25% we couldn't. We left something behind, and basically because of deterioration of monitoring and of facial nerve monitoring, and also the intraoperative finding that the dissection was difficult, facial nerve was very thin, and we were afraid we ruptured the fibers.
Thank you. I guess Professor Kono
we try to go up to the, you know, up to the the limit. So we don't
Right.
stop very early. Yeah.
Yes, yes. Maybe Professor Kono and Kondo want to say something about this. Probably they follow the same strategy.
Yes, I'm using continuous facial monitoring, and the condition of the monitoring and vascularity or facial nerve running course, long course or short course, or tumor hardness, softness or hardness, contency. So depends on many kinds of elements. So I will stop taking the tumor 95% or 97% resection. So not total removal is not the only goal. So facial nerve preservation is the first, most priority goal. Maybe same condition, I think.
I totally agree with that, Professor Kono. And if you have that good medical technician monitoring for that facial nerve, I think that they can warn that it's like a limit to stop that surgery or something. But we are not always doing the surgery in the same situation, so that's that we should learn something more about the surgical field. And Professor Kono mentioned something about the contency of that tumor is one of the key of that removal. Since that I have just one case is that if that tumor is hard, and we should remove that facial nerve is occasionally loaded severely. So that case is that the facial nerve is injured like that. So in that case, it's that the contency of that tumor is one of the good factor to stop the surgery. I totally agree with that.
Thank you. I see there is a question from Dr. Mayank.
Hello. Yes. I am Dr. Mayank. I'm doing my fellowship currently under Professor Kato in Nagoya. I would like to ask Professor Tathajiba. I'm a young neurosurgeon. He talked about the tubigen line and the IAM drilling. I just wanted to ask, how do you, Professor, manage, if you encounter ASL, how do you manage paradoxical CSF rhinorrhea? Any strategy to prevent? In our institute, we used to plug it with a muscle and some glue. So what is your opinion on that?
Yeah, this is a very interesting point. I didn't include this in my lecture, otherwise it would become too large. But it's a very important point. First of all, we have CT scan, thin slices CT scan, bone window of all cases before surgery. If the area we have to drill is completely compact, you have compact bone, you don't have air cells, you don't need to do anything. You don't need to plug anything. You can leave like this. But in 1/3 of the cases, you will find air cells and even big air cells. So in order to open the canal, you will open the air cells. What we do nowadays is under endoscopic view, under directly view of the drilled area, we put bone wax. I close all these cells first with bone wax under endoscopic view, and then I put muscle and fibrin glue. So in the past, we have done this only under the microscope. We had CSF leakage rate of 11%. Of course, most of them you treat with lumbar drain. You don't need resurgery, but 11%. Now we have dropped this rate to 3%. So 3%. And almost all cases can be treated with lumbar drain. So resurgery is very uncommon. Okay. So, but the method I prefer nowadays is close the air cells with bone wax and then muscle and fiber glue if you have opened air cells.
Thank you, Professor. Thank you.
Welcome.
Thank you. I think endoscope really gives something crucial to this kind of surgery. I agree. Sachin, you have a question.
Yes, thank you very much, Dr. Alberto, and thank you very much, Professor Marcos Patagiba, for a wonderful lecture. Continuing that discussion of endoscopic neurosurgery. So recently, I'm very much impressed with the endoscopic access for the neurosurgery, the minimally invasive neurosurgery. And in Fujita, at the moment, I'm in Fujita, and I'm learning endoscopic neurosurgery. And here we have certain professor, like Professor Watanabe, performs endoscopic vestibular Schwannoma surgery. So I would like to ask Professor Patagiba and Professor Kono also, what is your opinion about endoscopic assisted excision of vestibular Schwannoma? Will endoscopic assisted excision of vestibular Schwannoma will become popular in future, or will microsurgery will continue to be the main strategy for performing, especially for this kind of tumors? Thank you.
Maybe Professor Kono can start answering.
Yeah, about the endoscopic and exoscopic surgery, my opinion, we can do that, but it takes time too much, not speedy. So of course I like using microscope in a very, very, very short time, but why we have to do the longer surgery using exoscope or endoscope? That's my answer.
Yes, I think endoscope it's excellent tool. In my opinion, particularly to show the internal auditory canal, to check the fundus, if there is tumor remnant or not, and in order to close the air cells. So then I see advantage of the endoscope in comparison to microscope. For tumor removal, I could not find this advantage. So I use the microscope. And maybe someday we may find more advantage of endoscope in tumor removal. So in my opinion, so far, I don't have seen this advantage. But for checking the internal auditory canal, yes.
Thank you very much.
Dr. Jankovic.
Yes, thank you very much. Vielen Dank für hervorragenden Vortrag. I want to ask regarding to the follow-up protocol, checkup protocol after resection. Is that 3 months in the first year and then 6 months, or you have something special for Ausstiebingen?
Our protocol is after surgery, 3 months after surgery, and then every year for at least 10 years.
Thank you.
Thank you. Are there other questions? I have a question for Professor Patagiba and also Professor Kono and Kondo. When you open the internal auditory canal, maybe this can be useful for young neurosurgeons. Which landmarks do you use? You all mentioned about opening the canal very deep, very extensively. So what are your limits? What do you use to say, okay, that's enough, or not good to move over?
Again, we do an analysis of the MRI. There are some tumors, they don't go up to the fundus. So in these cases, I don't need to go up to the fundus. I can stop earlier. If the tumor is growing up to the fundus and the patient has no hearing any longer, then I go straight up to the fundus. I don't care about labyrinth block, okay? But if the patient has hearing, then I do care about the labyrinth block. In this case, I open about 7 millimeters. So the canal has about 10 millimeters. I open about 7. You can touch the fundus with a nerve hook, and then you know how far you are. And I leave this last part. Then I try to remove the tumor without seeing the end of the tumor. If it's possible, because sometimes it's easy to mobilize this part of the tumor. If it's not easy, then I try to combine with the endoscope and use angulated instruments. So there are some angulated Japanese instruments I use for this for this maneuver.
Thank you. I see. Dilshad, you have a question?
Maybe I would like to listen the opinion of Professor Kono about the internal auditory canal as well.
Yeah.
We use the preoperative very thin sliced CT scan, not MRI, for measuring the diameter we should drill. So different from Tatajiba, but so we don't have to drill so much for the small extension into the internal auditory canal patient. So same opinion to Tatajiba.
Thank you, Professor Kono.
Yes, and I totally agree with that. Most of the doctors, and also I think we should discuss about the question of the degree of the openness of the internal auditory meatus, since that the length of that diameter and the shortness, I mean that the wideness of the drilling of that. And Alberto asked us about that how to understanding about that wideness of that drilling. I think that we can use that specific, like a drill head is also one of the good mark to understanding that how much we can drill out that internal auditory meatus. And also that the point I want to emphasize here is like you should open the widely at least that 180 degree of that internal auditory meatus, since that we could access the lobe-like aspect from that internal auditory tumor if you can open the widely for that auditory meatus like that. That's just my opinion.
Yeah, thank you, Professor Kondo. And I also think maybe you are experts. You should mention also about the tools you use to drill, because I saw from the videos you use a drill, high-speed drill. Nowadays, there are also other instruments like bone scalpel and other methods. So I would like to know your opinion. And my question is due to the fact that, for example, when we do anterior cranioidectomy for any reasons, in my experience using the bone scalpel, so ultrasounds may injure the optic nerve. There are some cases reported about this. So I would like to know if, in your opinion or in your experience, you had such problems with the nerves in the internal meatus using instruments like the bone scalpel.
I don't want to emphasize that what the instrument is best, but it's depending on the surgeon. But I have to say that the speed of the drilling is totally that the drilling has a strong merit of that drilling of the bone. And if you want to use that ultrasound system, I think it's taking more time about that. And if you have that some good reason why that you don't like to use the drill, is depending on that like a cotton or a heat injury or something like that, and we can control that the cotton and the heat injury. So that if you wanna need a speed to drilling out that meatus or skull base, I think that the drill is the best instrument for that. It's my opinion.
Professor Kono and Tatajiba?
Same.
Yeah, I've seen, I'm faster with the drill. the bone scalpel, I was not satisfied. I was not happy for that. And I prefer to open the canal as first step, because the tumor will protect the nerves. You know, if I have removed the tumors and the nerves are all exposed, then it's more dangerous. And I start using 3 millimeters drill, always diamond, and not cutting drill. So 3 millimeters, then I move to 2 millimeters, and then finally 1 millimeter. In Germany, we can reuse the drill. We don't need to throw it away.
Oh, that's why you are using 3 for 1 patient. Okay, so Dilshad, you raised your hand. You have a question?
Yes, thank you so much, Professor Tatadjiba and Professor Kono, Alberto, everybody. I've been in a fellowship program with Professor Tatadjiba. He showed us very beautiful surgeries with beautiful results like here. He showed us again. I want to just acknowledge his efforts for the education of young neurosurgeons again. And I have a question about the position of facial nerve in these vestibular schwannoma cases. Is it in every case beneath the tumor, or it can be shifted to a side, or it can be lifted to the upper parts of the tumor, or in every case it is the beneath of, and what kind of preoperative diagnostic workup except usual MRI can be done in the case of vestibular schwannoma, like fiber tracking of facial nerve, or do you use these kind of technique of diagnostics to save the facial nerve or to track the facial nerve preoperatively? Thank you.
So thank you for your kind words. The problem is the cases where fiber tracking can show the facial nerve nicely are the cases you find the nerve during surgery also nicely. And the cases where the facial nerve is difficult to find and dissect are exactly the cases where fiber track is not showing very well. So now we are not using these as routine because of this. Fortunately, cases of posterior displacement of facial nerve are uncommon. They exist, but they are very uncommon. It's less than 1% of the cases. And most of them, the facial nerve will be found on the anterior part and superior part. And the technique we use is to first to debulk the tumor, and then we turn the tumor, we elevate the tumor, and then the part of the nerve which would be on the anterior side will turn to the inferior side. You know, you bring the facial nerve to the inferior part of the tumor, then you can dissect this. So this is the way. I don't know if I answered your question.
Thank you, Professor Tatadjiba. Are there other questions from the audience? Issue?
No.
Okay. So we should close this part of the webinar. I want to really thank Professor Tatadjiba for a great lecture and for very informative discussion, and also Professors Michihiro Kono and Akihide Kondo for giving their contribution, active contribution to this discussion. And now I would like to move on to the next speaker. And Professor Ishu Bishnoi, maybe you want to introduce our second speaker.
Yeah, thank you, dear Alberto, and thank you all, Professor, for such a wonderful session. So I would like to invite our next speaker, Dr. Sachin Chimate. He's a neurosurgeon, consultant neurosurgeon at Noble Hospital, Pune, and he's a chair of 𝐴𝐶NS YNS committee and member of WFNS Young Neurosurgeons and member of WFNS Young Neurosurgeon Award Committee. And currently he is doing fellowship at Fujita Bantane under Professor Yoko Kato. He will be speaking on endoscopic neurolysis of trigeminal nerve in case of trigeminal neuralgia without neurovascular conflict and its efficacy. So it's an interesting topic, and I would like to invite Professor Dr. Sachin to present his presentation. Thank you.
Thank you very much, Dr. Ishu, for the introduction. Am I audible clearly?
Yes.
Okay. So first of all, I'm very glad and honored to present in front of Professor Kono, Professor Kondo, and Professor Tatagibba. After his very the high-level talk, my talk will be little basic talk, and I would like to thank Professor Yoko Kato for the opportunity of doing a fellowship at Fujita University Bantane Hospital, and Dr. Alberto for inviting me to for today's webinar. And today I'm going to talk about the efficacy of endoscopic internal neurolysis for trigeminal neuralgia without vascular compression. And this is going to be my plan. First, I'll be talking about what I was doing before coming to Fujita, why endoscopic and why internal neurolysis, those two important questions. And this is actually a small research I'm doing about the efficacy of endoscopic internal neurolysis, and I'll present the result of that particular research. I'll also talk and end my presentation with the pathogenesis of internal neurolysis and its comparative analysis with the SRS and various ablation procedure. So to start with, this was my patient which I was operating. Is he audible?
Yes.
Yeah, so that was a very severe bout of facial pain. Especially you can see he is localizing in the V2 and V3 area. And he was so much in pain that he was not able to speak at all. And on the radiology, obviously, there was a good vascular loop which was seen. And this is what the surgery which I had performed. I will show you the surgery so that I can tell you what was the wrong thing I was doing before. So I performed this surgery as endoscopically, and of course, I used to do a wide. I performed this surgery microscopically. I'm sorry, and I performed a big opening. And as you can see down there, there's a fifth nerve running there, and I could not reach to the fifth nerve. And there is a superior petrosal vein there, and I cauterized that superior petrosal vein. Actually, I used to do that regularly. When I realized that it should not be sacrificed always. But in this particular case, I was not able to have any access to the trigeminal nerve without taking out that vein. So I had to sacrifice it. And then after the sacrification, I could see that there's a vascular loop, and I took a big Teflon and put in between the loop and the trigeminal nerve. And of course, this was the result of the patient after the surgery. He was more confident. There was no pain at all. So the surgery was, principally, it was successful. So then the question comes, why should I do the endoscopic surgery when everything is going pretty well okay? So the answers are, first of all, it is minimally invasive. So all those answers, which, are routine answers, like minimally invasive means less blood loss, less invasive, the shorter duration of the patient in the hospital and the early discharge. Those are the usual answers for that. And they are very important answers, actually, because sometimes while doing a microscopic surgery, when you do a bigger opening, you have complications like hitting the sinus and bleeding. And when you take out the superior petrosal vein, the infarct because of that. So all this can be minimized when you're doing the endoscopic. When you do microscopic, you always take out the vein. I used to take out the vein always, but when you do endoscopic, you have this 30-degree endoscope, so you don't really have to take out the vein. Even if the vein is coming in your vision, you can use the 30-degree endoscope and reach there. Here now in Fujita Bantane Hospital, we don't put any Teflon, we use the transposition. So we take the loop and fix it over the tent or the dura. The ICG is very important. As you can see in this particular picture, we have this particular endoscope, Carl Zeiss endoscope, which has intraoperative ICG, and we can see the live streaming, live running of the different colors, and you can identify whether it is artery or vein and whether it is an offending vessel or not. And at the end, of course, doing endoscopic is more elegant way of doing it. You are a better surgeon, and even the patients are happy. So that's why endoscopic. Now, the second question, why internal neurolysis? Because all of us know there are many patients with the trigeminal neuralgia who actually do not have this vessel compression like this picture. This is a special MRI technique called a fusion image, in which we've got the brainstem, we've got the vessel, we've got the nerve. So you can see the fifth nerve here and the loop of the vessel running. So this is a classical trigeminal neuralgia. But in some non-classical trigeminal neuralgia, you don't really have the vessel in contact with the nerve, and then you don't know what you exactly to do. So let's start my introduction. So trigeminal neuralgia can happen with or without neurovascular conflict. And while microvascular decompression is the most effective treatment for trigeminal neuralgia, it is not possible when there is no vascular conflict in principle. And microscopic internal neurolysis is being practiced and published, but not the endoscopic. So I will tell what are the advantages of endoscopic neurolysis. So the aim of this particular study was to sort or to evaluate the safety, efficacy, and durability of the endoscopic internalysis, endoscopic internal neurolysis. They also called it as a nerve combing, as if you are combing your hair, you are combing the fifth nerve. So all these patients are from 2022, 1 year, 2022 at Fujita Health University. So obviously it was a retrospective review. The pain scale was assessed by a Barrow Neurological Institute pain scale, and the hypostasia scale was assessed by Barrow Neurological Institute facial hypostasia scale. So just let me show you what, first of all, this endoscopic internal neurolysis, how it is performed, and then I'll take you the result. So we put the patient in the park bench position, 3 centimeter incision just behind your ear, and you make a very small, that is 1.5 centimeter keyhole at the transverse sigmoid junction just behind that, just below and behind the asterion point. And what you exactly need for doing an endoscopic procedure is good pneumatic endoscope holder, and we use a Mitaka holder here. You need a special instrument like single shaft instrument, because through this 1.5 centimeter keyhole opening, you're going to pass your 6 to 7 mm diameter endoscope, and you should be able to pass your instrument. So instrument should be very tiny. So single shaft instrument like single shaft scissor here, single shaft dissector, and you need an irrigation suction. That is very important, because sometimes it is a half dry, half wet technique. No brain retractor, obviously. Professor Komatsu Fuminari uses a very nice sort of like, stepping down approach. He will take small patty, put the endoscope there, again another small patty, put the endoscope, another small patty, put the endoscope. So you step down towards the trigeminal nerve strategy. So endoscope, you have a better visualization of trigeminal nerve bundle. Now this is very important because of the paranomic view. You don't see this trigeminal nerve bundle very clearly in your microscope, but endoscope gives you a very clear view. Like, as you can see, this is the 7th nerve below, 7th and 8th nerve. This is the 10th. So this is the cranial and caudal. And you can see the 5th nerve. So you can see V1, V2, and V3. So you can do your internal neurolysis there, since you are able to see the bundles very clearly. So we perform 2 things. One is nerve massage and internal neurolysis. And I'll tell you what are the significance of all those techniques in the coming slides. So that is basic procedure of endoscopic internal neurolysis. Let me show you the video. So patient in the park bench position, that is our incision marking, and make a very small, you can see the opening is just 1.5 centimeter, and slowly you step down towards the trigeminal nerve. As you can see here, the superior petrosal vein is there, but we are not sacrificing it, because we are using 30-degree endoscope and we are able to sort of see it from the angle. And this is what is the internal neurolysis. So let me pause the video here. So you are actually able to see the bundles here, 1, 2, and 3, and in between the bundles, the bundles are always anatomically arranged in an order that V1 is always cranial, that is towards the above side, V2 is in the middle, and V3 is always in the caudal. So depending on the pain location of the patient, the area of distribution of the pain, you can target your internal neurolysis. So internal neurolysis is nothing but you enter your dissector in between the bundles of these fibers and sort of disrupt this bundle. So this patient particularly had pain in V2 and V3 area. So we target the V2 and V3 bundles and do the internal neurolysis. As you can see, this nerve was totally virgin. There was no any artery or vessel or arachnoid adhesion which could possibly explain the cause of the pain. So let me tell you the result of this particular study. So in 2022, in Fujita, we performed almost 99 endoscopic trigeminal neuralgia patient. The classical ones were 82. So in those patients, we performed the MVD, endoscopic MVD. The secondary, because of the tumor, were 3. The idiopathic trigeminal neuralgia is the trigeminal neuralgia patient without any neurovascular conflict were 14 patients. And this was the data of the 14 patients. So let me walk you through this data. The age. So you can see the average age of the patient was around 50 to 60, but you can see there's some patient of 40. So recently, what we observed, there is a trend of having trigeminal neuralgia in little young patient at the age of 30 to 40, and we should have a definite treatment strategy to this patient, especially in the patient without any vascular conflict. We had 8 male patient and 6 female patient. Side, we didn't have any side predominance, although according to literature for classical neuralgia, the left side is more prominent, but maybe for idiopathic neuralgia, we don't have any such literature. So in our literature, in our results, we had equal number of patients, 7 patients on the left side, 7 patients on the right side. Now, as per the literature, V2 is the most affected area, and V2 plus V3 is the second most affected area. And we also had the similar distribution. This is V1, V2 alone, V3, V1, V2, V2, V3, and V1, V2, V3. That is the left one-sided pan-facial neuralgia. So as you can see, V2 and V2, V3 was the most common area involved, which was the result was same as the literature. The pain scale. So we use this Barrow Neurological Institute pain scale. So class 1 is no pain, class 2 is occasional pain, but no medicine required. Class 3 is some pain, adequately controlled with the medicine. Class 4 is some pain, not adequately controlled with the medicine. So these are the patients who need surgery. And class 4 is severe pain and no pain relief with any sort of medication. So you can see the left one, the red column is before surgery, and the yellow one is after surgery. So you can see most of the patient actually had class 4 or few of them had class 5. And post-operatively, most of them we were able to achieve to 1 or 2. That is, there were no pain or very occasional pain, but they did not need any medicine. One patient on some follow-up needed some medication. So that was a good result. But there's one drawback, one sort of a complication of performing internal neurolysis is the hypoesthesia, because you're directly creating an idiopathic damage over the nerve. So we assess the sensation or the hypoesthesia based on this Barrow Neurological Institute hypoesthesia scale. There's 1 is no facial numbness, 2 is mild facial numbness, but it is not bothersome, so that is okay to acceptable. 3 is somewhat bothersome facial numbness, and 4 is very bothersome facial numbness. So you can see there are 5 patients who had mild facial numbness, and the rest of the patient didn't have much facial numbness. Now, why this is important? Because we were able to selectively do the internal neurolysis. Unlike CyberKnife or the other ablation procedure, where they are not very selective, so you get more facial dysesthesia. Now, one problem was follow-up period because all these patients were operated in the last year, that is 2022. So the longest follow-up was 10 months and the shortest follow-up was 2 months. So that is one drawback of this particular study. But we would like to follow this patient over the long term and see what are the long-term results of internal neurolysis. This is the literature review. Now, as you can see from 2022, right from 2009, all these different studies and the treatment strategy which they have performed with microvascular decompression and internal neurolysis, but none of the study which actually had endoscopic internal neurolysis. They might have performed the endoscopic MVD, but no endoscopic neurolysis. So our study was probably the first study to publish the endoscopic internal neurolysis. Now, let me talk a little bit about the selective neurolysis. As you can see, once the V1, V2, and V3 forms the trigeminal ganglia, and they run into the cysternal portion and then go into the brainstem. When they go through the cysternal port, they maintain this demography. That is, V1 will be in the cranial, V2 will be in the middle, and V3 will be in the lower half. So, like that, like this is the brainstem, this is cranial, this is caudal. V1 will be always above, V2 in the middle, V3. Now, why is this important? Because if the patient has V2 and V3 segment pain, then we should do the internal neurolysis in that particular segment and should not do above. And that actually avoids unnecessary V1 segment facial hypoesthesia, which cannot be avoided in different other modalities like cyberknife or ablation procedure. So, just that video again. So this patient has V2, V3 segment pain. So you can see that we were targeting and doing this internal neurolysis with the plate dissector particularly in that area. So that is the selective neurolysis is what is very important. Now let me come with this comparative analysis because this is very important because most of these patients who do not have any neurovascular conflict, the treatment strategy we apply is either SRS or some percutaneous technique because we can't actually perform microvascular decompression because there's no vessel. So about internal neurolysis, what is the mechanism of action? The immediate mechanism of action is it destroys the continuity of the axons because we're directly putting a dissector in between the bundle fiber and we disrupt the interbundle connection. So immediately it disrupts or destroys this continuity of axon. It disrupts the interbundle connection and thus decreases the electrical excitability of the abnormal trigeminal afferent fibers, which eventually going to enter into the brainstem and then going to go to the cortex. Over the long term, because of this disruption and it permanently degenerates the partial axon tissue and the myelin sheath after a period of time. So because of this immediate and long term, you actually get immediate pain relief and long-term pain relief. So this is more promising. One disadvantage, as I mentioned, is facial hypoesthesia. But as I said, this is more selective. So you can avoid the unnecessarily facial hypoesthesia is that if the patient do not have pain in V1 or V2 or V3, then we don't create a facial hypoesthesia there. Like one of the major complication after facial hypoesthesia is the corneal sclerosis. That is the facial hypoesthesia in the V1 segment, which can be avoided. The advantage of this procedure is more beneficial in younger, because in younger patients, we should provide more promising treatment, a treatment which will not have a recurrence after a few years. And it is more selective, as I said, for V1, V2, V3 segment. Unlike that, SRS mechanism of action is a localized radiation injury, which actually disrupts the transmission of the pain signal to the brain. The dose is around 70 to 90 gyri in single setting. The pain relief, there is no immediate pain relief in SRS. It generally takes some time, around 2 to 4 weeks, unlike internal neurolysis, which gives immediate pain relief. And the average pain-free outcome, that is most of the studies which use SRS, say that average pain-free outcome is around 3 years. After 3 to 4 years, it is going to recur. So the disadvantage is facial hypoesthesia because it is not selective. So you have a gross facial hypoesthesia and not a selective facial hypoesthesia. And as per the different studies, the literature says is around in 50% patients. The recurrence of the pain occurs after 3 to 4 years, as I said. The advantage is more beneficial in the older patient who are not the candidate for surgery. or who are not cooperative for the percutaneous technique. About percutaneous technique, it is nothing but causing a damage to the nerve by heat, that is thermal ablation, by chemical, that is glycerol, and by mechanical way, that is balloon compression. Advantage, it gives immediate pain relief because it directly disrupts the nerves. Disadvantage, it causes sensory loss, and again, as I said, it is non-selective because it is done all under the radiological guidance, and you can't actually distinguish between V1, V2, and V3 bundles. So the limitation of my study was a smaller number of subjects. I had only 14 patients and small duration of follow-up. Maybe I would like to follow up this patient over the long term, and then I can constructively tell about the long-term efficacy of this particular study. So at the end, the conclusion, so this is our operation theater actually. We've got the Carl Zeiss microscope, and which comes up with this huge screen, so where you can actually see the bundles more clearly and more selectively. You can do the internal neurolysis. So this is the first report of the endoscopic internal neurolysis with the meaningful outcome data, although microscopic internal neurolysis has been performed. This study demonstrates that internal neurolysis is safe, effective, and durable treatment for trigeminal neuralgia in the absence of neurovascular conflict. The pain-free outcomes with the endoscopic internal neurolysis appear to be more durable than the radiofrequency ganglioglysis and stereotactic radiosurgery in our series. Given the younger age distribution of the patient in this group, consideration should be given to performing of internal neurolysis as an initial treatment as compared to the cyber knife and the ablation procedure. And the accrual of further outcome data is warranted, and would like to follow up this patient for the long term. These are my references. I'd like to thank you, Professor Kato and Professor Kamatsu Fuminari, who have performed these surgeries. So thank you very much. Thank you.
So the session is open for the discussion.
Yeah, I think we can first ask Professor Hirotoshi Sano if he wants to give initial comment. Professor Tatajiba told me he had to leave, but if we still have Professor Sano online, maybe he can give his comment.
Yeah. Thank you. Thank you, everybody. And recently, I'm thinking about this, especially the acoustic neuroma and this endoscopic trigeminal neuralgia. But the endoscopic trigeminal neuralgia can do everybody, but acoustic neuroma could be, we have to grown up the specialist, or everyone should be learn. So I'm recently thinking about we for the patient, maybe we have to make up some specialty better, but everybody want to be to learn. So these things I am for some dilemma. Also the AV malformation and my a little bit giant aneurysm, such kind of things must be make some centralization. And these things is now all thinking about. Yeah, then that's my comment on the question.
Thank you, Professor. And we have also Professor Kondo and Kono.
Yes, Sachin, how's everything? Congratulations for that.
Okay. Thank you very much.
Okay. So congratulations for that your wonderful lecture. And I also agree with that we need to have that another procedure for trigeminal neuralgia, since that if we have a lot of patient who has not have the exactly that vascular compression, so that's that I already checked that the internal neurolysis is one of the let's say that next stage of treatment of that trigeminal neuralgia. However, still we have to clear that patient doesn't have any like a secondary region, which is happen to have that V2 area for that some tumor or some like inflammation and something like that. So do you have any specific idea for that excluded that secondary trigeminal neuralgia before or you go to the internal neurolysis?
Okay, Kumbawa Kondo Sensei, thank you very much. I'm doing fine. So the answer to your question is, first of all, for all these patients, we do MRI, a special MRI, that is the CIS technique of the MRI, in which we do the fusion images, and we see two things. One is whether there is any vascular compression over the nerve or not, and whether there is any tumor or not. So with the MRI technique, you can actually define whether it is a classical or secondary or idiopathic trigeminal neuralgia. That is one thing. But about the secondary trigeminal neuralgia or idiopathic trigeminal neuralgia, the treatment is going to be same thing. So what happens when you treat a secondary trigeminal neuralgia, you remove the nerve, you remove the tumor from the nerve. So while doing that, you are actually handling the nerve. And when you handle the nerve, that is one form of doing neurolysis. You are handling the nerve. So as per the Sudan's classification of nerve injury, there are 3 nerve injuries, that is neuropraxia, exotomosis, and neurotomosis. So when you remove the tumor from the nerve, you handle the nerve. So that is, you have created some form of a idiopathic small damage to the nerve. And that damage is enough to relieve the pain. Same concept applies in the idiopathic trigeminal neuralgia. When there is no tumor, no vessel, you just handle the nerve that much that it is not causing a permanent damage, but causing that much damage that patient's pain is relieved. So that is the main concept. Thank you.
Okay. Okay, I totally agree with that. One of the good idea to do that internal neurothesis before giving them that some specific radio-surgical treatment. So that's it's good, and I totally agree with that. And also that using that endoscopic is a good idea. Since that if you get a good resolution of that trigeminal nerves, which means that we can identify some adhesion or some inflammatory changes of the trigeminal. So I just will have a good interest for that your procedure. Thank you for your lecture.
Thank you. Arigato.
Maybe Professor Kono is still here.
I think he left, I think.
Okay. Issue, there are maybe some questions from...
Yeah, so Yanko, do you have a question? Yeah.
Just a second. Yes, I'm on. Thank you very much, Sachin, for the great presentation and very beautiful results. I have one question regarding to the recurrence. Can you tell us, do you have some experience or do you have some results regarding to the recurrence of the pain or of the trigeminal neuralgia?
So as I said, these are all the patients which we had operated last year in 2022. So the follow-up of the patient was the major problem. The maximum follow-up which I could have was 1 year, and the minimum follow-up was 2 months. The patient was operated in December. So as of now, in no patient we had a recurrence. So maybe I would like to follow up this patient over the long term and assess the efficacy of the internal neurolysis, whether in long term it's really effective or not. But as of now, there's no recurrence. But there is few patients, around 4 or 5 patients had problem with the facial sensation. But as I said, it is up to grade 2. That is some facial dysesthesia, but it is not too much bothersome. They are able to manage. Thank you.
Okay, thank you very much.
There is one question from attendee, the Dr. Ahmed Fawad. He asked that, do you continue the medication after surgery? One. And what is your advice for medical management for persistent pain and no possibility for surgery?
Okay, now let me answer that. First of all, of course, we continue those medicine, all carbamazepine and gabapentin after the surgery, and it needs to be continued, and we taper them slowly. That is one thing. About the patient who have pain even after the surgery, that you need to have really strategic plan for this kind of patient. One thing, you again have a radiological assessment and see whether there is again any vascular loop or the Teflon which you put has caused any Teflon granuloma or not, or the loop which you have transposed again came back and hitting on the nerve or not, one thing. And if you don't see any cause for the recurrence radiologically, always have a neuropsychiatric assessment of this particular patient, because sometimes when this patient who have pain for a long period over the time, even though you treat them successfully intraoperatively, they continue to have some sort of pain, and some antidepressant medicine does help to reduce this pain. So that is the answer. You continue the medicine, and if recurrence, have again radiological and neuropsychiatric evaluation.
Thank you, Sachin. So I have one question. Like the interneurolysis, it is giving some trauma to the nerve fibers. So we are talking about the positive effects that it benefits by creating myelination. I'm talking about negative effects that it can cause damage to the nerves and lead to neuroma formation. And then that can cause an intractable neuralgia in future. So maybe you may find some recurrence in these cases because of the neuroma formation caused by the internal neurolysis. Because otherwise, yeah, okay.
Yeah,
First,
so thank you very much. And I'm always happy with your questions. You always ask some very sensible and strategic questions. So first of all, I'm sure you must be doing some peripheral nerve surgery. So that's why you know about the neuroma formation, about the internal neurolysis, after internal neurolysis. But unfortunately, I did not see any case reports. And in our series, we didn't have any neuroma formation. And maybe I can explain that in a way that, see, this trigeminal nerve is not one nerve. The three roots, the V1, V2, V3, they come together and form the nerve. So it's just three bundles who are together for a reason. And if you disrupt this bundle very carefully, I don't think it is creating that much damage to the nerve that it will lead to a neuroma formation in the future. So we are just separating these nerve bundles who have come from different places and formed. So that's the answer to your question. I hope I answered.
yes. So that explains that it is not a complete internal neurolysis. It is separation of these three nerve branches, and that's how we do. We are not opening each nerve root. Like we are not opening the endoneurium and separating the internal fibers. Yes, that concept must be understood, because if a new beginner is doing this internal neurolysis without understanding this concept, he may land up in causing more injury rather than treating the cause.
Yes. So correctly said. As I said, the student's classification of nerve injury, the neuropraxia, neurotomosis, the exotomosis and neurotomosis, you should be limited up to neuropraxia only, or maybe a little bit of exontomosis, but should not cause a neurotomosis that you are killed the nerve. So
yes.
Yeah, also because in that case, probably there would be no difference compared to the percutaneous lesional treatment, right?
Exactly.
So, Sachin, congratulations for your very nice talk.
Dilshad wants to say something.
Oh, yeah, Dilshad raised his hand.
Hi, everybody. Thank you so much, Sachin, for it was a new idea for me, actually, internal neurolysis. And I just wanted to ask about the technique. Is it mandatory using an endoscope, or is there a possibility to do this technique through a microscopic technique? I mean, not using the endoscope.
So thank you very much. And for the question. So as I mentioned in my case series, in the literature review, already internal neurolysis is a known thing, and it has been practiced microsurgically, that is with the help of microsurgery, with the help of microscope. The advantage of using an endoscope is two things. One is when you use an endoscope, you have a 30-degree camera, so you can actually go around. And sometimes because of the superior petrosal vein, when you're not able to reach there, you are able to reach without sacrificing the superior petrosal vein. One thing. Second thing, in endoscope, you have this panoramic view, which is more closer to the nerve. And when you go more close to the nerve, you actually see these bundles more clearly, which maybe in the microscope you may not be able to see. Maybe higher end microscope like KINEVO or Leica may be able to see. But in endoscope, even if you have a lower power endoscope, still when you go close to the nerve, you'll be able to appreciate the V1, V2, V3 separately, and then you can take your dissector there and selectively do internal neurolysis. So endoscope has some advantage over the microscope, but it's not that microscope cannot do it, you can do with microscope. Thank you.
Sachin, I also have a technical question for you. You know, I am a big supporter of endoscopes in general. But you know, sometimes preoperative images, okay, most of the times preoperative images give you a good vision of what you can expect during surgery. But in some cases, this is not true. If there are some, probably you can rule out arterial neurovascular conflict, but in some cases you have some small veins, which is very debated, but sometimes you can find them. Or there are some people claiming that arachnoid bundles around the nerve, not inside the nerve, can be responsible for this kind of problem. So my question is, if you have ever faced in your experience or in a Japanese experience such a situation when you find actually there is a conflict either with vein or with thick arachnoid around the nerve, and how easy is it to manage this situation with such a small approach and with the endoscope?
Yes, thank you very much, Dr. Alberto. I was scared of your question because you are a big expert in endoscopic neurosurgery. I'm still beginner. So the answer to your question is one thing. As Professor Kamatsu Fuminari and Kato Sensei, whenever we see these arachnoid adhesions, arachnoid granulations around the optic nerve, and especially at the Meckel's cave and at the root entry zone, where they are causing some sort of a tension there, and because of that the vein is become stiff and it's not that movable, we always release this adhesion. We always reduce this adhesion. One thing. Second thing, now artery is known to cause the conflict and the pain and the trigeminal neuralgia. But there are some case reports in which even vein, if it is sitting bang on the root entry zone, it can be the possible cause of trigeminal neuralgia. And in such cases, of course, you cannot mobilize or transpose the vein to the tent because that's too difficult and not possible. So in such case, we sometimes put small ornament, small Teflon in between the vein and the nerve. So principally, when you go inside, you don't leave any possible cause for the recurrence. You just overdo little bit, mobilize the artery, do internal neurolysis, do the adhesions also, and if possibly small vein, put the ornament and come out. So that try to avoid the recurrence, possible recurrence in the future. Thank you.
Thank you, Sachin.
Am I learning endoscopy clearly or not, in your opinion?
I think you are exposed to a very good neurosurgical endoscopy over there. So that's good. That's good. Congratulations, Sachin.
Thank you.
So
your topic is very nice.
Yeah, very nice and very interesting. I think, you know, new generations must be able to handle endoscopes. Of course, the endoscope cannot replace a microscope or, you know, compete with exoscopes, but we must have this tool in our hands. Maybe we have some other questions, issue or from the audience.
No. So are there any other questions? Any comments? Professor Kato?
Professor Kato.
So thank you very much for a wonderful session. Just I want to thank you, Professor Kondo. Kondo Sensei will be the future Japanese Congress president. So Japanese Congress, of course, everybody knows, focus on the young neurosurgeon. So I think Kondo Sensei will have may have a very nice program for not only the Japanese YNS, but also the international YNS, I think. We hope. And also the Juntendo, the Professor Kondo Sensei is the chairman of the Juntendo University, is very famous in Japan. And also his colleagues is one of the best endoscopic neurosurgeon. There are so many cases in the Juntendo University. So I think some of you want to visit because Tokyo is very close. So just you can visit him. And also, of course, he showed us, maybe he will show us the orbital tumor or whatever that he is, also skull-based surgery. いいですか、近藤先生。
Yes, of course, that I'm going to have that kind of like a session open for the Asian neurosurgeon and also young neurosurgeon, and maybe that the confliction with the Japanese young neurosurgeon with the Asian neurosurgeon is one of the like key to develop the basic techniques for the neurosurgery. So that I'm going to welcome you all. And if we could have that a good time and sharing that the experiments is wonderful for us too. So hopefully have a good visit to Japan and Tokyo. Thank you.
So is it 2025 or 2026?
Actually 25.
25. That is 2 years after. Okay, so please keep in mind. Okay. And also we had a very nice session with Professor Kono. Already Kono Sensei has left, I think. But we are so happy, and we learned a lot from both of them, and then discussion with Professor Tadachiba. We are very lucky today. And also the super commentator, Professor Sano Sensei is going to Hawaii from now, I think. He's waiting for the flight. So he's attending the international meeting in Hawaii. So have a good flight, Professor Sano.
Thank you.
Thank you very much for
now in the airport.
Thank you so much.
Okay.
So Albert Sensei, thank you very much for your episode tonight.
Thank you.
Arigato. Wonderful talk.
Arigato.
Excellent talk.
Arigato.
Yeah. So I also want to thank you, Professor Kato, for these closing remarks and for all the comments. We had a really great session today. Thank you, Professor Sano. Double thank you to Professor Sano, not just because he gave us his insights, but also because he connected from the airport. So we are very grateful. Thank you so much. And it was a pleasure to see you again. And we had 2 great talks today by Professor Tadachiba and by Dr. Sachin. We really, I think, learned a lot. And this is also thanks to the discussants we had. Professor Ahikide Kondo, thank you so much for joining us and sharing your experience and your comments, and also Professor Michihiro Kono. Thank you, Isshu Bishnoi, for helping me in the moderation of this webinar. And I want to thank all of you who joined us today, and have a good Sunday evening. Maybe most of you are in Asia, so konbanwa, and have a great week next week.
Oyasumi.
So bye-bye.
Oyasumi.
So this shows, thank you very much. So
Thank you.
Make a plan. Okay.
Yeah.
Bye-bye.
Thank you so much.
Bye-bye. Bye. Bye.
Bye.
Thanks.